Hello there. I'm David Brenner, the Vice Chancellor of Health Sciences, and it's my pleasure to moderate today's health talk. I can't think of a more exciting, interesting topic than today's topic, which is entitled Parents, Kids, and COVID, What You Need to Know. Since most schools are opening or already opened in San Diego, everyone is thinking about how the pandemic affects our children and how we will deal with schools and children's normal needs for interactions going forward. And particularly, as of yesterday and today, probably the hottest topic in the country is vaccinations for children. So we are really lucky to have this group of amazing experts to educate us. We have 5 experts in different aspects of pediatrics: Dr. Mark Sawyer, Dr. Kelan Tantisira, Dr. Stephen Spector, Dr. Shin Sun, and Dr. Kerri Boutelle. As you probably know, the practice of pediatrics occurs at both UC San Diego Health, as well as at our affiliated Rady Children's Hospital. And between us, we see a large number of patients and have a large experience, and in particular about children with COVID and vaccinations. I also want to thank Dr. Gabby Haddad, who is the department chairman of pediatrics, and who has really provided the leadership to put together this group, and as well as many research and clinical programs in pediatrics. So we will start with Dr. Mark Sawyer. He's professor in the Department of Pediatrics here at UC San Diego School of Medicine. And he is also a temporary voting member for the FDA Vaccines and Related Biological Products Advisory Board. So he will teach us about the status of vaccination in California and in the nation. Dr. Sawyer.
Good afternoon. It's great to join you. I agree with Dr. Brenner. This is a quite timely topic. I'm going to kick things off today with some general comments and introduction of issues that are relevant to consideration of vaccines for children with the new COVID vaccines. So we hear this question a lot: do kids really need COVID vaccines? I'm sure you're all aware that children in general are less severely affected by COVID and as an infection, and that leads some to question the need for vaccine. But I've included in this slide some of the statistics around COVID in children in the United States. We have had over 4 million cases, 17,000 hospitalization, which compares to or is maybe slightly higher than what we see typically with influenza. We've had over 500 deaths in the United States from COVID, which is more than we see with influenza. And most importantly, perhaps, children play an important role in the transmission of COVID to their family members and to others. So I think the arguments are pretty compelling that children do need vaccine, and fortunately we're on the cusp of vaccine being available to us, and you'll hear more about the details of that shortly. The graph on the right simply shows the rate of COVID disease in children under 4 in the yellow line and in 5 to 11-year-olds, and it's following the same peaks and valleys as we're seeing in the general adult population. I do want to spend a minute talking about vaccine effectiveness as a statistic, because you hear that discussed a lot, vaccine effectiveness. And there's all kinds of different versions of what vaccine effectiveness might mean. So we start on the left-hand side of this figure with a SARS-CoV-2 virus. The best vaccine would be one that prevents all infection. So you don't get infected, you don't get symptoms, nothing happens. The next best vaccine would be one that keeps you from getting infected, but it may or may not keep you from transmitting the infection to others. So that's a separate measure of effectiveness. It would be great if these vaccines prevent transmission. Even if you get infected, you don't have symptoms, but you stop transmission. And then as we move off to the right, we just escalate the outcome. You could have a vaccine that doesn't prevent symptoms, but keeps you from getting sick enough to go to the doctor. You can have a vaccine that prevents you from getting put in the hospital. You can have a vaccine that keeps you out of intensive care and ultimately dying of COVID. And the rate of effectiveness changes with each of those outcomes, going up as you go from left to right. So this is a very important thing to keep in mind, especially with the Delta variant that's circulating now, that vaccines remain effective at keeping you out of the hospital and dying of COVID, even though we are seeing some decrease in immune protection from having symptoms or even getting sick enough to go see the doctor. So you should keep this concept in mind as you're reading about vaccine effectiveness. So what are the goals and challenges in considering COVID vaccine in children? Of course, we want to prevent severe illness leading to hospitalization and death. We're worried about some of the long-term effects of COVID in children, just as we are in adults. We need to interrupt the transmission within schools and to family members. And, from a parent's point of view, perhaps most importantly, we want kids to get back to their normal activities in school and their sports and other things out of school. It's a very important thing, though, that we be careful about moving forward too rapidly in children. So, as with any vaccine, we're always considering the risks and the benefits of a vaccine. We're weighing the outcomes that we just talked about versus any side effects from the vaccine. In adults, it's pretty straightforward, particularly in elderly adults. The risk of the infection is so great that there's really not much question that we can tolerate some side effects in the vaccine. But the risk for children is different. The risk of outcome of infection is not as severe. So we have to be extra careful as we consider vaccines for children. So the risk-benefit balance is different in adults and children. And that is among the reasons it's taking so long for us to get a vaccine for children. The other thing I want to introduce is the vaccine approval process. There are two main steps to that. And you've heard a lot about this in the news in just the last few days. The first is the FDA, the Food and Drug Administration, which has an advisory committee listed there. The role of FDA is to approve vaccines based on safety and effectiveness, and it's largely based on data that the manufacturer submits to FDA. So FDA can't do anything until the manufacturer submits their information. So one of the delays sometimes in the rollout of a new vaccine is the company takes longer than we would like to actually submit the data. But once the data is submitted to FDA, it's reviewed, the advisory committee often meets and gives their input, and then the FDA makes a decision. And we are waiting for that very step right here today on the question of booster doses that has been in the media and was discussed last Friday by the advisory committee. The next major step is the CDC, the Centers for Disease Control, which has its own advisory committee called the ACIP. It's the job of CDC to take a vaccine that's approved by FDA and tell us who should get it and when they should get it and what the priorities should be. They're also responsible for vaccine distribution and oversight of distribution. So it's a two-step process. In the question of boosters that I just mentioned, the CDC is meeting Wednesday and Thursday of this week to come up with the final recommendations for the use of booster doses. And we'll see this same two-step process when vaccines come available for children. How do we know if vaccines are safe? And how do we know they're safe for children? Well, we know a lot about vaccines in children in general and the immune response based on decades of experience. We have clinical trials in younger populations with different doses, and you'll hear more detail about that. I think the most important thing to be aware of is that there is an extensive post-marketing surveillance or real-world experience that we learn from as vaccines are used in the community. And it surprised me a little when preparing for this that we have given over 5 billion COVID doses around the world. So if there was a strange or unusual, extremely rare side effect, we would know about that by now. And I've listed here some of the systems that are in place, and the acronyms are not that important, but let me just mention two of them. VAER is the Vaccine Adverse Event Reporting System up at the top. This is a system that allows anybody, a patient, a family member, a doctor, to report what they think might be a side effect of a vaccine. And then the CDC and the FDA investigate to see if that really is a true association. And one way they investigate is with what's called the VSD, the Vaccine Safety Data Link. This is a group of managed care groups that have electronic health records. They have something like 10 million people that they can study to say after they got a COVID vaccine, what happened? And that's the best scientific way to determine whether vaccines are safe. And these systems are in place. They're monitoring vaccine side effects every day. And we're going to rely on those to tell us whether vaccines are safe. Let me wrap up by saying, here's where we are with COVID vaccines in San Diego. In the 12 to 17-year-old population, we have actually managed to immunize almost 70% of that adolescent population, which is great news. We have some work to do. Among the things we need to keep working on is there are some disparities across different regions of San Diego, as we've seen in adults, and there are disparities by race and ethnic groups. So we still have work to do, but we're making great progress with the rollout of vaccines. And finally, a lot of the questions that have come in so far have to do with, well, how do we get back to school, particularly in the setting of the Delta variant? I do want to make sure everyone's clear that pediatricians and the national organization, the American Academy of Pediatrics, supports having kids get back to school. We are seeing gaps in education. We're seeing inequities in education. School is very important for socialization and emotional skill development of kids. And we're unfortunately seeing rising mental health disorders in children as a result of the COVID pandemic. What can you do to protect your kids in school? Well, getting them vaccinated for sure when that becomes available, but don't forget all the other steps. Masking, schools have increased ventilation. We need good hand washing. We need you to not send your kids to school when they're sick, and social distancing to the extent that's possible. And you put all that together, I think it is safe for kids to get back to school. With that, I'm going to turn it back to Dr. Brenner and our other speakers.
Thank you so much, Mark. That set the tone perfectly. So next we're going to have Dr. Kelan Tantisira. He is the chief of the Division of Pediatric Respiratory Medicine and Pulmonology at UC San Diego Health, as well as at Rady Children's Hospital. And he will discuss COVID pulmonary disease in children.
Thank you, Dr. Brenner. I appreciate the introduction. And I'm pleased to speak with you today about how COVID impacts the lung in children. As Dr. Sawyer mentioned, we've recently seen this impact of the Delta virus, particularly in pediatrics. And in fact, most recent statistics from the CDC actually suggest that some pediatric age groups are actually leading in terms of recent incident cases. And that's also been reflected in terms of the kids who are getting sick. We've actually seen a spike in emergency room visits as well. And so clearly making clinical studies of COVID-19 paramount in the current day and age. So why would we want to study SARS-CoV-2 as it affects the lungs? Well, I think that there are at least, obviously multiple, but at least two predominant reasons. And the first is that we know that respiratory transmission is actually the predominant way that SARS-CoV-2 gets transmitted from individual to individual. And I've shown that on the left. It's either via airborne or droplets from person to person, as well as somebody who is infected can actually cough onto the contaminated surfaces, whereby other individuals can make contact with that and then get infected. The other thing is that SARS-CoV-2, actually, the lung is a primary target organ, and the airway epithelial cells, which are the surface cells of the lung, are primary targets in that they all express this ACE2 receptor to which the SARS-2 COVID virus binds to create that downstream effects. So I would be remiss to mention that there are clearly extrapulmonary manifestations as well as pulmonary manifestations of COVID. And amongst those in kids, the things that we most commonly see are that about 15 to 40% of kids actually remain asymptomatic, which actually does mean that the majority of kids do get some symptoms. The most prominent non-pulmonary symptoms include effects on the gastrointestinal system. And then in the sicker kids, we always worry about the multisystemic MIS-C type of presentations in those kids. Having said that, the most common overall presentations for COVID are seen on the right-hand side here, in that most commonly it's either non-specific in terms of fever or cough, which is present in about 50% of individuals. Now, while shortness of breath itself is not the most common manifestation, for the kids that present to the hospital, it is a very common manifestation. It's seen in about 40% of individuals. And in fact, locally at Rady Children's Hospital, of the individuals who presented, who were hospitalized with COVID, approximately 33% of those presented with respiratory symptoms, and about half of the individuals that wound up in the intensive care unit also had respiratory symptomatology as their initial presentation. So I mentioned that COVID is a multi-systemic type of disease. And indeed, you can see that for both acute manifestations as well as post-acute or chronic manifestations, COVID can certainly affect many systems within kids. From a respiratory perspective, what we worry about the most acutely is pneumonia and the possibility of hypoxemic respiratory failure or acute respiratory distress syndrome, ARDS. From a long-term perspective, we have seen a large incidence of kids with persistent symptomatology, including shortness of breath that lasts for months after the initial infection, whereas kids, even with kids that did not have any underlying lung disease. So what does this look like clinically? Well, I thought that I'd give you a overview based on lung radiology. And on the left-hand side, you see perfectly normal lungs. And the perfectly normal characterization of the lungs is we have the white blood vessels, and then everything else is black, and that is air on these x-rays. As you get more acute, you see that the vast majority of hospitalized kids, including 15% of children that are totally asymptomatic but test positive for COVID, actually do have lung abnormalities, the so-called ground glass abnormalities that you see here, where you see the haziness, this whitish gray haziness that it affects the lungs in place of the nice black normal lung tissue. And as you get sicker, that haziness and the ground glass opacification can progress onto focal consolidation or pneumonia that you can see here. And then frankly, into this ARDS or the hypoxemic respiratory failure, where basically the vast majority of your lung turns from aerated tissue into non-aerated tissue that is replaced, as you can see on this CT scan. The incidence overall is about 30% of intensive care admissions. And overall, this results in about a 5% mortality rate for all ICU admissions for COVID in children. So histologically, what would this look like? Again, I'll take you through a normal slide. This is what your normal lung looks like under a microscope. And even those with very mild abnormalities, this ground glass opacification that present really with no respiratory symptoms whatsoever, actually you can see some distortions in the lung architecture here, as well as fluid filling in some of these alveolar spaces. Another less common presentation is those of pulmonary embolism or blood clot within the lungs themselves. And then that child that I showed you, the 1-year-old with ARDS, unfortunately, this is post-mortem examinations, and you can see classic feature of ARDS with marked distortion overall of the lung parenchyma and with demonstration of the COVID virus actually within the lungs themselves. In addition to that, even individuals that really have no symptomatology, you can see that COVID is demonstrated within those lungs despite no respiratory symptomatology. Now, I mentioned that there are both acute as well as post-acute sequelae, and our group at UCSD is actually conducting a study in conjunction with the NIH Recover program as far as post-acute sequelae of SARS-CoV-2. And I listed for you just the respiratory sequelae that we have seen, and you can see that it's relatively common in terms of all the individuals who have been followed at UCSD and with our collaborators up at UCSF to see respiratory sequelae symptoms, meaning far greater than a month later, you still have significant dyspnea, shortness of breath, coughing, or wheezing that was not pre-existing. I will point out to you that one concern that we've had is that this incidence for both acute COVID as well as these sequelae symptoms is markedly enriched in individuals of Hispanic or Latino ancestry. So while we know a lot, and I know that there will be a lot of questions today, there remain a lot of questions that we are trying to seek to answer in terms of pulmonary manifestations of SARS-CoV-2. Included amongst these is, what are these subclinical lung abnormalities? As I mentioned, 15% of children have GGOs even when they're asymptomatic. What is the natural history of all these lung abnormalities and respiratory symptomatology in terms of chronic sequelae? Are there any novel therapies on the horizon? And why is so much of COVID, including specifically related to respiratory symptomatology, increased in disparate communities? And having thrown those questions your way, I will turn this back over to Dr. Brenner and the rest of the presenting panel. Thank you.
So thank you so much. That was incredibly helpful, and it really correlates what other people are saying. So I am now going to turn this over to Dr. Spector. Dr. Spector is chief of our Division of Pediatric Infectious Diseases. He has also run several of the critical clinical trials on vaccinations for COVID-19, both in adults and in children. So he will really give us insights into what to expect for vaccinations and results of clinical trials. Thank you, Dr. Spector.
Thank you, Dr. Brenner. And so when will COVID-19 vaccines be available for children less than 12 years of age? Well, as you heard earlier, what is clear is that we need to have vaccines for young children. And I won't go into the details that Dr. Sawyer went into, but I just want to talk about on a population basis why it is so important. If you think that there are 331 million people in the US, and we're going to need, based on what we have seen with the Delta variant, that 80 to 90% of the population will be needed to achieve herd immunity. So they're going to need to be protected. Children who are less than 12 years of age comprise over 50 million of our population. So if we're going to achieve herd immunity, we need to be able to immunize children who are less than 12 years of age. Now, you've also heard and seen that the frequency of infection in children is going up, particularly as the Delta variant has increased. And what is quite interesting and important to note is that since March of 2020, children have comprised 16% of COVID-19 cases in the US. However, for the week from September 2nd to September 9th, this year, children comprise 29% of the cases of COVID-19. And to put that into perspective, here in San Diego, what you can see is with the number of cases of children who are 0 to 11 years, you can see, in fact, that there's been a marked increase with the Delta variant, and as children have started going back to school, and the number of cases in children are now comparable to that of those in San Diego County who are older than 60 years, and for adolescents between 12 and 19 years. Fortunately, serious infections and hospitalizations and death remain low in children. As you know, there are currently 3 COVID-19 vaccines that are approved within the US, either through an EUA or, in the case of Pfizer, actually been licensed. 2 are messenger RNA vaccines, and 1 is a non-replicating viral vector, the J&J Janssen vaccine. As of now, the Pfizer vaccine is approved either through EUA or a licensure for those who are greater than or equal 12 years of age. The Moderna vaccine has an EUA for those that are greater than 18 years of age. They have an application in to have licensure of their vaccine for over 18 years of age. And they also have pending for those that are greater than or equal to 12 years, an EUA for that group as well, that we should hear about in the next few weeks. The J&J vaccine is going to be studied in children as well, but is not as far along as Pfizer or the Moderna vaccine. So why are COVID-19 vaccines taking so much longer in children? Well, as you heard from Dr. Sawyer, risk benefit is one issue, but in actuality, vaccines are historically tested first in adults and youth who are older than 18 years of age. But importantly, children are not little adults, and you have to come up with what is the right dose, because the dose of the vaccine necessary may be lower in children than that in adults. Additionally, the immune response may differ in children, and also the adverse effects may be different. Importantly, if we know the efficacy in adults, as we do with the COVID-19 vaccine, this can expedite the approval in children, because in the COVID-19 studies, what we are now looking at is the immune response that we're seeing in children comparable to that is seen in adolescents and in adults? And also, is this vaccine safe? So if we can demonstrate immunogenicity and safety, we can then have a licensed vaccine for children. So as you heard yesterday, I'm sure on the news and saw on the front page of the San Diego Union this morning, the Pfizer vaccine seems to meet the criteria that we would like for a vaccine in children from 5 to 11 years of age. Of interest, the children received a 10 microgram dose, 21 days apart, which is 1/3 of the dose of that's given to adolescents and adults. They enrolled over 2,000 study participants in that study that were randomized 2-to-1 to receive the vaccine or to receive placebo, and found that the immune response was comparable to that seen in adolescents and adults, and the adverse effects were similar as seen also with adolescents and adults. They are also studying in children 2 months to 5 years of age, a 3 microgram dose, which is 1/10 of the dose that they have used in adults. And they're expecting to apply for EUA for their 5 to 11 years by the end of this month or the beginning of October. For an EUA 2 years to 5 years, sometime at the end of October or the middle of November. And for those that are 6 months to less than 2 years, sometime in late November or December. As far as the Moderna vaccine, they are also studying children who are 6 months to less than 12 years of age. This is a study that we are doing at Rady Children's Hospital. And this study has already enrolled over 4,000 study participants between 6 years and less than 12 years. They are receiving a 50 microgram dose, which is half the dosage that has been given to adolescents and adults. And again, as you may know, the Moderna vaccine is given 28 days apart. The end of the second dose should be completed by this Saturday. And the expectation is there'll be an EUA application to the FDA by the middle of November. They're also planning on starting their study on 2 years to less than 6 years and 6 months to less than 2 years of age in the middle of October. And this is also a study that we will be doing at Rady Children's Hospital. So where are we? What is the estimated timeline for the approval of COVID-19 vaccines for children less than 12 years of age? Well, the expectation then is for children between 5 and less than 12 years of age that, again, the EUA for Pfizer should go to the FDA sometime by the end of this month or October. And one would anticipate that sometime by the end of October, the beginning of November, that there will be an EUA for the Pfizer vaccine for children 5 years to less than 12 years. For children 2 years to less than 5 years, the expectation is that that will take about a month longer. And by the time we have an EUA application that would be approved by the FDA. I would anticipate that that would be more in December, and towards the end of this year that we would have an EUA for children 2 years to less than 5 years. For children that are 6 months to less than 2 years, it'll take a longer period of time. My expectation is that the application will not go to the FDA until late in December, and likely it will be sometime in the first quarter of 2022 that we will have a licensed vaccine for those children 6 months to less than 2 years, and that will cover all the children who are less than 12 years of age. So I will stop here. I'd be glad to answer any questions later, and I'll turn it over to Dr. Brenner.
Hello there. I was told that Dr. Brenner is having issue with his sharing. So I'm just going to go on with my presentation. So I'm Xin Son. I'm a professor in pediatrics in the Division of Pediatric Respiratory Medicine. My team studies pediatric lung disease mechanisms. And in the next few minutes, I hope to tell you about what we know and how we discover COVID-19 viral infection in the young lungs of infant and children. So on the background slide here, what you're seeing is a human lung section with magenta staining the cells that are infected by the SARS-CoV-2 virus. So let me just quickly remind you that SARS-CoV-2 stands for Severe Acute Respiratory Syndrome Coronavirus 2. As Dr. Tantisira mentioned, that the lung is then a primary site of the SARS-CoV-2 infection. So the picture on the slide here is a mouse lung stained with the airway in magenta that conducts the air from outside environment and deliver the air into your gas exchange unit, stained in green here. So in an average adult human being, you and me, we have 6 million on average of gas exchange units in our lung. And this amounts to about 1,000 square footage of gas exchange surface area. And that's about half of a tennis court when you think about that, all packaged in our chest. And one piece of a fact is that 95% of the surface area is actually built after birth. So in children, it's an active, evolving, building organ that is functioning as our gas exchange tissue. So on this slide here, it depicts the particular cell layer that's in different parts of the lung that faces the outside environment, and that's the epithelial cell layer that Dr. Tantisira also mentioned, that forms the barrier that protects the rest of our body away from the pathogens that come from the inhaled air. So I think about the SARS-CoV-2 infection as in 3 steps. The first step is the entrance of the pathogen, and the cells facing it are those epithelial cells. There will be an infection process, interaction with the pathogen and the cells. And following that, your body hopefully mounts an immune response, and that then leads to the virus clearance. And after the viral clearance, the next step would be the repair of the damage in your lungs. So the activation of the good stem cells to repair the lost cell types. So the next 3 slides, I hope to tell you how the young lung behaves in comparison to the adult lung in those 3 steps. So the first step, as I said, is infection. So the virus infects the cells. They need actually receptors for the virus on the cell surface. So to address the expression of those receptors for virus on different cell types, what we use is a advanced technique called single-cell RNA sequencing to address in the human lung cell types, how many of these receptors are expressing what cell types. So in this map here, which looks like impressionist painting, each dot here represents a single cell. And when a cell expresses similar genes, these dots will congregate into a similar cell type. So using this, we were able to interrogate for any genes that are expressed in our tissue, how much are they expressed and where are they expressed. So Dr. Tantisira mentioned ACE2 is one of the key receptors for SARS-CoV-2. There's another gene that encodes a protease called TMPRSS2 that is also essential for virus entry into the cell. On the right-hand side here is a map where each of the black dots is detection of the gene expression. On the x-axis is a list of cell types. So you can see for both of these two genes, the black dots are more enriched on the left-hand side, and these are the epithelial cell types that I mentioned earlier that are forming the barrier to protect our lung away from the outside environment. So these tend to be also the cells that express higher level of the receptor compared to the other cell types. So then we focus on these cells and look at these two receptor gene expression and compare their gene expression level in the adults versus pediatric lungs. As you can see here, so for both of these genes, the expression of these genes that are important for viral entry is expressed at a lower level in the pediatric lungs compared to the adult. So we think this might contribute to why there is a lower infection rate in the pediatric population, is because the young lungs express fewer of those SARS-CoV-2 entry proteins. So that's good news for the young lung in the steps of infection. So the next step is immune response. So shown on this slide here is a section of a mouse lung infected with another respiratory virus, the influenza virus, and stained in green here are your immune cells. So we can see here that there is a huge amount of immune cells that's recruited into a lung upon the damage by the virus to try to clear the virus. So here, as I mentioned earlier, the young lung is still building after birth. So the young lungs have a naive immune system, which then leads to a poorer defense against pathogens compared to the adult. So that's bad news. So the good news is that there are ways to educate the immune system, as the prior speakers all talked about. Vaccine is one of the ways to educate your immune cell system to boost these specific immune cells that would be in action to clear the virus. So the next step is repair the lung after the virus has been cleared. So shown here again is a mouse lung section showing that these pink cells now are coming into this damaged blue region to repair the damage. So there are two kinds of repair. There is the good repair, which is shown in those green cells here, which are where the stem cells have been activated to transition to gas exchange cells. There's also bad repair where the stem cells have transitioned to scarring tissue, shown in orange here. So we want to obviously boost good repair and minimize the bad repair. And the good news here is that young lungs have more active stem cells that is very good for the good repair compared to the adult lungs. So to just summarizing the comparisons here, for the young lungs, they are better at conducting less of infection because they are expressing less of the receptors. They are also better at repair because they have good stem cells. For the immune response part, it's something that we can do. We can work on. We can boost the immune response through vaccination. So hopefully that's some information that will be helpful for you, and we continue to address the question using our research approaches. And with that, I'd like to turn over back to Dr. Brenner and the next speaker.
All right, thank you so much. I apologize to the doctor's son. As you realize from hearing her speak, she is a developmental biologist who's a world expert on the development of the lung. And our final speaker is Dr. Kerri Boutelle. She is both in pediatrics and psychiatry. She's director of the Center for Healthy Eating and Activity Research and she's going to talk about the psychological and behavioral impact of the pandemic on children. Kerri.
Hi, everyone, and thanks for inviting me. I just thought I'd start off by talking a little bit about how the pandemic has affected children's lives. So if you think about it, there are a number of different things that happened during the pandemic. So we had school closures, online education, lack of in-person social interaction, isolation, loss of supplemental meals at school, family stress, parent telecommuting, increased exposure to substance use and maltreatment in the home. On the positive side, there's increased parental contact with children and opportunities for more involvement in play, decreased physical activity, increased ability to overeat because families were stockpiling packaged foods, increased risk of cyberbullying, screen time, and finally, there's all the mental health issues that come along with fear and worry, grief related to loss of loved ones, substance use, cancellation of youth sports, and closures of playgrounds. So this is now called the psychosocial wave of COVID-19. So COVID-19 and the pandemic had profound impacts on family life. So parents play a crucial role in providing stability. During this time, they had to balance work and childcare responsibilities, provide home education to children who are online schooling, manage infection control, and also provide emotional and psychological support for their children. Many families had financial stress, abuse and substance abuse effects on the family were exacerbated, and some families had more time for play and other activities together. I used to think, I don't know who has all that time, but somehow people made it. So online learning affects child's mental health in a number of different ways due to disrupted routines, stress related to online learning, decreased access to mental health services, lack of identification, report, and support for use without abuse and maltreatment, missed free and reduced price lunches, challenges learning, especially for kids with pre-existing learning disorders, lack of social connection with youth, and in particular, challenges for older children who are trying to form more complex relationships and have higher stake academic outcomes. So in one survey of over 2,000 parents showed that older children in remote schooling had more mental health difficulties than those who were in person, and Black and Hispanic children as those with lower income in remote schooling also had greater impairments in mental health. So compared to parents of children receiving in-person, parents of children receiving online schooling reported decreased physical activity and time spent out time, decreased in-person time with friends, and worsened mental health or emotional conditions. They also had job stability concerns, childcare challenges, conflict between working and providing childcare, emotional distress, and difficulty sleeping. For depression and anxiety, about a third of US parents reported that their child was more sad, depressed, or lonely since the pandemic. There was an increase in depressive symptoms and suicidal thoughts, more than before the pandemic in data reported in China. Another study showed that through 8,000 adolescents, 43% had depression and 37% anxiety. And parents report things like their child had difficulty concentrating, they were irritable, they were bored, they were worried, and they also had anxiety. In terms of body weight, my team and I study weight loss, overeating, and binge eating in youth. So we were especially interested in this. And on the left-hand side, you'll see the average change in body weight from pre to post-pandemic for different age groups, 5 to 11, 12 to 15 in the middle, and 16 to 17 on the right. On the right-hand side, you'll also see the percent of youth who meet the criteria for overweight or obesity, again, by the same age groups. The blue bars are pre-pandemic, so March 2019 to January 2020, and the green bars are March 2020 to January 2021. And as you can see, there's an average change in body weight pre to post-pandemic, pretty significant ones for the younger ones, the 5 to 11 and the 12 to 15, whereas 16 to 17 were, I guess, somewhat protected. The percent of youth who have overweight or obesity in 5 to 11 rose from 36 to almost 46% during that time. 12 to 15-year-olds, again, were hit from 38 to 44%, but again, it relatively stabilized in 6 to 17-year-old. In substance use, we have some positive and negative effects. In one study with e-cigarette users, about 2/3 reported that they reduced their use. Another study with 16 to 18-year-olds after social distancing was instituted. We saw decreases in binge eating. This is the kids reporting decreases in binge eating, decreases use of marijuana and vaping. A recent publication out of UCSD on the ABCD study, which is 21 sites and over 7,000 youth. They found that fewer youth were using alcohol and more youth were using nicotine or misusing prescription drugs, possibly due to access. So what have we seen in terms of mental health visits to the ER? There's been a national increase in the proportion of visits to the ER for mental health reasons since March 2020. Here at Rady Children's, we had from July to mid-September of 2020, we had 576 visits for behavioral health, i.e. psychiatric emergency visits. And that number went to 702 in the same amount of time in 2021. This represents a 30% increase from 2020. Rady Children's also has a medical behavioral unit, which is a unit specifically for patients with psychiatric disorders and medical comorbid disorders. So here you will see the left-hand side is 2020, and you can see as the pandemic begins to lift, here's where you see some changes. The admits, the average daily census increases for the MBU and continues on through 2021. In terms of outpatient, I'm also affiliated with the UCSD Eating Disorder Center. The green line is the number of families that called with an adolescent with eating disorder concerns, and the blue line is pediatrics. You can see the same thing, that the number of calls increase once some of the restrictions are lifted, suggesting that potentially anxiety or other triggering events may have led to these increases in calls. So on the right-hand side is my daughter. This was her first day of school as a senior. And I did find some data to support this, but she wanted me to remind all of you that she actually really was happier during the pandemic. She said it was so much easier for her. School was easy, it didn't take as much time, and there was reductions in social pressures. Research supports some of this with belongingness and relationship with peers, feeling stronger to some adolescents, hope, meaning, and life satisfaction, and a better feeling of community. So I got asked a number of questions about children with higher levels of anxiety. So anxiety regarding the pandemic is real. Sometimes reassuring kids sometimes can exacerbate the anxiety. You want to limit kids' exposure to the media, help your child feel in control through hand washing and masks, and obviously vaccinations when it's time. Explain the physical effects of anxiety, so how it's a fight or flight mechanism, and teach your child deep breathing. And if your child's anxiety is severe and persists and interferes with their everyday lives, please reach out for help. And there are a number of different resources available, as well as on the CDC. So with that, I will say thank you and hand it back to Dr. Brenner.
That was some amazing presentations, and I got an enormous number of questions, some of which you've answered, you've anticipated some. There's a lot of questions about vaccines for children and dosing and weight. Why, maybe it's good for Stephen, why are not the doses adjusted by weight? There's a big difference in the weight of a child who's 5 versus 12.
Right. Well, in general, as you've seen, the dose that was given for those who are 12 years of age and older is is the same dose as given to adults. After that, what actually ended up happening with a number of these vaccines was that, in fact, there was a dose finding study that was performed prior to their actually going into the registrational trials. And what they found there was, in fact, that very often lower doses of the vaccine were able to give an immune response in people who were less than 65 years of age. So when it came to looking at what dose would be appropriate for younger children, what happened was the companies began to look at those in phase 1-2 studies, found that in fact the lower doses gave the immune response similar to that was seen in adults and was associated with fewer adverse events And that's why they went with the lower dose.
I'll just add in that there are lots of vaccines that have a different dose for younger children compared to adults. And if you think about it, there's quite a variation in the size of adults. So
Good point.
And in fact, with the influenza vaccine, when you're older, you get a bigger dose. So there are differences in vaccines and doses.
Yeah, I thought maybe a take-home message was it's not dependent on your body weight, it depends upon how you respond to the vaccine. So that's why some more senior adults require bigger, antigen loads to get a better better response. Here's a good question. What about the risk of COVID transmission in breast milk?
yeah, I just reviewed this for a talk I gave yesterday, and there's actually no convincing evidence that COVID or SARS-CoV-2 is transmitted in breast milk. And there is also very little evidence that it's transferred in utero through the placenta before the baby's born. So the vast majority of babies who are getting infected, and we do see that, are getting infected after they're born. So it's important for women and families who have SARS-CoV-2 infection to be very careful around the newborn, because they are more severely affected than older infants and older children.
Thank you. Here's a question that I always doesn't seem to make sense to me either, as well as a questioner. So, you're wearing masks all the time, and then you sit down and eat in the schoolroom, and you take your mask off. There's a whole group of students eating together without masks. It doesn't seem intellectually consistent. Anyone have any thoughts about that?
Well, go ahead, Stephen.
I was going to say you're absolutely right, but it's hard to eat with your mask on.
Yes.
Yeah, in most facilities, the recommendation is when you take your mask off to eat, you need to distance yourself at least 6 feet from others. Unfortunately, in schools, that message may have gotten lost, or it may be challenging to do that given the space available.
When the children here's another question. When the children get hospitalized, is there any underlying disease conditions they have, or, like similar to adults, where it seems like there's a very high predisposition of underlying diseases that get you from mild COVID to more severe colon?
The majority or plurality of hospitalizations are associated with comorbidity. And what the pediatric literature supports, the number one comorbidity that we actually see is obesity as an increased risk factor for hospitalizations. There are other, immune deficient syndromes and any other underlying disease tends to make you more likely, but obesity is the one thing that the literature continuously cites as an increased risk factor for hospitalization.
Thank you. Here's a question for Dr. Sun. Someone said, if you're not being vaccinated yet, in other words, your child's not ready to be vaccinated because of the age limits, is there anything else they can do to, I think the term you used was educate their immune system?
Play in the dirt. It's one way to do it. Just ways to expose to low doses of different antigens, things that will present to you your child's immune system, to have them mount a little response, a little bit at a time, so that will diversify the immune cells, get them ready.
Here's a good one for Kerri. It says that the children have enormous amount of anxiety. What should the parent do? And maybe a more tougher question is, at what point do you ask for professional help? When does normal anxiety extend into something that you need an intervention?
Okay, so I've been asked this question a couple times actually, and one of the best things you can do, as I said, is talk to your child about their fears. Their fears are real. Parents can also educate children that sometimes anxiety feels really awful because it's a physiological response. And so, as I mentioned briefly at the end, because I was running out of time, that you can teach deep breathing. When to refer or when to go for help, that's a judgment call. But at some level, if it's affecting your child's functioning, where it seems severe and ongoing, that would be the time to call for an assessment. And it's always worth getting an assessment. And if the therapist thinks the child doesn't need help, they will certainly say so. But in general, by the time people get there, they're usually worried enough to want to have their child have someone to talk to.
Here's one that Steve volunteered to answer. Thank you, Stephen. This is a misunderstanding about how you develop vaccines and the role of cells from aborted fetuses. So maybe you can clarify that, Steve.
Right. I think that this is really a very important question that is important to understand that this is not true and that these vaccines were not developed using fetal cells. They were not evaluated using fetal cells. And so it's very important. I saw what the question was, that families that are not getting immunized because of this understand that this is one of the things that is not true and should not be preventing them from getting immunized.
Thanks. I wanted to make sure everyone understood that. Then there are a whole series of questions, and maybe different people can answer this, about the relationship of a COVID infection to a child, whether it's asymptomatic, mildly symptomatic, or severe symptomatic, and then the risk of long COVID or subsequent symptoms.
Well, I wish we understood long COVID in anybody. It's a phenomenon that looks like it's real, but defining who it happens in and why it happens, I think we're still working on that. There have been reports of that in children. There may be a psychological component that Dr. Boutelle can comment on, but it is certainly a concern and one of the reasons it's important to immunize kids.
I would add to that. I think that long COVID is absolutely real, and the prevalence does seem to be increased along with disease severity. We know that Miss-C children, for instance, tend to have very long-term symptomatology. I would reiterate that the NIH is about to begin a nationwide study, which UCSD is one of the long COVID or post-acute sequelae of COVID study groups, in which they will be recruiting anywhere between 6,000 and 10,000 children across the nation over the course of the next year or so to really start answering some of those questions related to pediatric long COVID. They're doing it for adults as well, of course.
Thank you. Here's a similar question. All adults know the answer to this, but what about for children? What kind of short-term side effects have children shown to vaccines? Tiredness, headache, soreness, etc.
So far, children have shown the same side effects that adults and adolescents have shown. So just those side effects that you mentioned, Dr. Brenner, are the ones that we're seeing in children.
To the same severity? I mean, because it seems like, or is there a big range? It seems like in adults is enormous range depending upon how the reaction is to the vaccine.
Yeah, yes, and that's the same for children also that we've been immunizing. Some have virtually no symptoms at all other than a mildly sore arm, and others have had fever that has gone up to 102, and have had some chills and body aches. So we've seen a wide range, but again, they usually last no more than 24 or 48 hours.
And I'll just reiterate that that's a major focus of the FDA review of these studies to make sure that we're not seeing more severe side effects. So it's good news that we're not so far.
Yeah. And that actually, another question just addresses what Mark just raised, so maybe we can add to that about what does the FDA look for? I mean, what would be a cutoff that they would be concerned about not going ahead with vaccinating children?
Well, I mean, the fundamental equation is risk versus benefit. So you would look at the risk of hospitalization and severe outcomes, including long COVID and the psychological impacts of COVID on our society and transmission to others. And then you would look at the side effect profile and say, which is the more severe. And every vaccine that we have ever used routinely in the United States and elsewhere, when you do that analysis, you conclude that you're better off getting the vaccine than you are getting the disease. And I'm certain that's going to be true for COVID as well.
Thank you. Here's a question, probably for Kerri, about peer pressure, not to wear a mask, if you're among your friends, and Would you have any words of wisdom about how to deal with that?
So I wish I had some magic for that one, and I really honestly don't. You know, it's the same as we teach children to resist any other peer pressure, is one, find friends who are also like-minded, who want to wear a mask, and secondly, support your child in feeling comfortable standing up to the other teens, and then if necessary, get them support at school from either coaches or PE teachers or whoever can address the group. That would be my first thought.
I know the answer for adults, but not for children. What do you do as far as COVID-19 testing for children? Do we use the same PCR testing? Is it administered the same way? Where would one get one when we wanted it? And also, this was not asked, but I want to know the answer to this one. What about the antigen tests that you can buy in the pharmacy? How are those approved for children?
The testing for children is identical to that as with adults. The best test as far as the best accuracy as far as false positives and false negatives is the PCR test. The antigen test, although a very good test, is more likely to give you false negatives, and may also, depending on who's doing it and the interpretation, has also given some false positives. Testing can be done at many of the same places where adults are being tested, and children can also be tested, of course, at Rady Children's Hospital.
And I'll add to that, the testing is also happening in some schools. Some schools are using testing as a way to keep, things in check and to identify a problem early on.
Initially, I've heard less about this recently, but initially there was a lot of worry about what they call MIS in children. And can someone define what that is? And where does that fit into the spectrum of COVID-19 disease? Sounds like Kelan should know the answer. I don't know why. I have a feeling Kelan knows the answer.
No, so I'm not an MIS specialist, but MIS stands for multi-system inflammatory syndrome.
Yes.
In children, or MIS-C. And as I mentioned in my one slide, it does affect for the acutely sick kids. It does affect up to 20% of those that require ICU hospitalization and things along those lines. I know that at Rady Children's Hospital with our UCSD group, they are actively following approximately 70 of those children longitudinally to find out as much information as we can about them. So there clearly is an active group that is looking at them both from a clinical care perspective as well as from a research perspective.
At what point does a parent test his child for COVID-19? I mean, when they have the sniffles, when they're coughing, what would trigger you to do this?
Well, it's tricky because the symptoms of COVID in children can be very mild. There are kids can have no symptoms at all, but in general, the symptoms are the same as they are in adults. Coughing is one symptom, fever, not feeling well, but kids also get diarrhea. So I think, certainly if you suspect or know your child's been exposed in the family, or if you hear about an outbreak in school and they get symptoms like that, then that's a good time to test them. But testing or no testing, you definitely want to keep your kids home while they're sick so that you don't spread further infection.
Here's the question. It's almost the opposite of what I asked you first. Is assuming that the mom is vaccinated, is breastfeeding protective for the infant?
Well, there is evidence that for all IgG antibodies that they do pass into breast milk. And so conceivably those antibodies would be helpful, as well as just the immunologic benefits of breastfeeding. However, as children get older, and if we do have a vaccine that's available for those children who are 6 months of age or older, those children should be immunized, because one of the things that also is very helpful is the passive antibody from a mother who's been immunized either prior to her pregnancy or during pregnancy, that the passive antibody goes to the infant and can be helpful and protective in young infants. But as they get older, they lose that antibody. Breast milk antibody may be of some help, but again, you'll want to get those infants immunized once there's an available vaccine.
Right, but for now, is there any, if you breastfeed for 6 months, you breastfeed for a year, do you get continuous benefit from the vaccinated mom, or does that decrease?
Well, that's an interesting question. I don't think that there are data on that, but I think based on breastfeeding that it could certainly be helpful and would not be harmful. But I don't think we have sufficient data to say that it would be protective.
And then this is the same question always comes up for adults. If you had COVID and now you recovered, how does that immunity compare to a vaccination immunity? Do we know that?
Well, we don't have as much data in children as there are in adults. However, the expectation would be that it's very similar, that you do make immunity to the variant that you have been exposed to. There still is a big question as to how long that immunity lasts with natural infection. And one of the things that's been seen in adults that I think is important that has not yet been studied in children, but is something that will be important, is for adults is once an adult has been infected, when they receive a single dose of one of the mRNA vaccines, that they respond extremely well and seem to have a great deal of protection after just a single dose of the vaccine.
Very good.
And I'd just like to reiterate that that is the recommendation. Even if you know you've had COVID, you should still get vaccinated after a period of time to really boost your immunity.
Yeah, and for adults, I know, it's 90 days after the infection, they recommend you get it and you get a good response. Then there are questions. Oh, here's a good one for Kelan. Does asthma play a role in infectivity or severity of COVID-19?
Yeah, that's a great question. As it turns out,
he knows the answer to it, so he's all happy.
No. It's actually kind of a complex question. We've actually seen a dramatic decrease in asthma overall, but most of us are conjecturing that it's the COVID environment more so than the COVID asthma relationship per se. In terms of decreased asthma, although kids with asthma actually do not seem to get any, at least in those studies that have looked at it, any significantly sicker than kids without asthma who get COVID. So from that perspective, there have been no specific studies on transmissibility with or without asthma that I am aware of, but just from an overall sickness perspective per se, it doesn't appear that asthma significantly interacts with COVID along those lines.
Thank you. And then there are questions about all the other drugs that, not that many, but that have been used in adults, where they fit into children. For example, monoclonal antibodies, remdesivir, other interventions. I don't know about in the ICU, but certainly in the medical ICU, use of glucocorticoids or other interventions. So where does that fit in the armamentarium to taking care of ill children?
Well, all of those things are being used in children. We don't have as much experience as with adults because not as many kids are in the hospital, but certainly we're using the monoclonal antibodies both as prevention, as part of therapy after infection. So we're continuing to study those, and those are turning out to be a very important part of the equation.
Child-to-child transmission, because I guess that's one of there are a lot of questions sort of related to that, because the concern going back to school. Is that, do children have the same viral load as adults? Is the ability to transmit similarly? Are they messier than adults who are more likely to transmit? So there's a lot of questions about that, about concerned parents.
Well, there certainly now are sufficient data to demonstrate that there are situations in which there is child-to-child transmission. There also has been teacher-to-student transmission that has occurred. Again, the viral load with the Delta virus strain is 1,000-fold greater than what was seen with the original virus. And so that regardless of whether or not children have the equivalent viral load to adults, there certainly is sufficient virus when they are infected to transmit to their friends and potentially to their teachers, parents, and grandparents.
And reiterating a point that Shin made earlier in our lecture, that they have lower ACE2 receptor and therefore might be more resistant to infection. Has that clinically borne out as far as child-to-child transmission?
I don't know of any data that has actually systematically looked at that. I think that that's an interesting question. But again, the amount of virus that children have is certainly sufficient for transmission.
Right. We are out of time, but this is, as you can tell, this is incredibly well received and a lot of great questions. And you guys are just fantastic. You should take this on the road. This is really, really amazing. Thank you so much.